Okay, you're on, Kelly. Yay. So Kelly Yoakum is the president of the CCGG board, and she's going to welcome y'all in. You're on mute, Kelly.
You're muted.
So I'm just over here talking to myself. That's all, not unusual. Good morning and welcome to our spring showcase. We're excited to have you all here. If you've had a chance to look at the rolling screenshots, there's a lot of really great, hold on, we've got a giant thing here, Donna, on my end. You've had an opportunity to learn a little bit about the organization, but what I'd really like to remind folks is, in terms of what we do, our focus really is about education, advocacy, workforce development, and not unlike a lot of other organizations, we've spent this year kind of rethinking and reimagining ourselves as an organization. And I want to give a shout out to our board and our other members. We really have thought a lot about our vision and our mission, and even our bylaws. So those are all new to us right now. And what else do I want to mention here? Oh, shout out to the Education Committee. That's Amiko Takagi, Donna Jensen, Suzanne Bowmaster, Mary Marshall, and Maria Claver, who's our vice president, has thrown some work in there as well. So I'm going to go ahead and throw it back to Donna because I think I only have 5 minutes.
All right. I almost did the same thing, Kelly. 13 months into this and I still can't hit the mute button. So welcome. I just am going to give you a brief description of the day, and then we're going to, we'll dig into it. So we have 6 presentations today. Our showcase idea came out of the fact with the pandemic, we couldn't have our annual conference, and we were just all, number one, missing the opportunity to connect and engage in dialogue and learn about different things that people are doing around the world of aging around the state. And so we, because we had to stop the conference mid-planning last year, we had some wonderful proposals, and we wanted those folks to have the opportunity to present their research. And so we did, it wasn't called the showcase, but we did the little mini conference, and it was a huge success in terms of people coming and the dialogue and the things that we were learning. And so we decided we need to have this more often. And so we do a spring showcase and a fall showcase now. And so what you're going to hear today are folks that submitted proposals, and we went through a peer review process. And these are the folks that were accepted for the spring showcase. There's a mix of professionals and students. And so that's another lovely blend of CCGG. So each presenter is going to have 10 minutes to present their topic. And then there'll be a 2-minute question and answer period at the end of each presentation. You can raise your hand. You can put the question in the chat. We'll be monitoring the chat. If there's bigger dialogue that you'd like to have, or more questions that you'd like to ask, at 11 o'clock, we are going to have just a half hour of networking Q&A time so that you can ask questions, you can share with each other, and we can connect, because connection is something that we are certainly missing right now in terms of this professional organization that means so much to so many. So that's kind of how we're going to flow.
Yeah, Donna?
Yes.
I just want to throw in there a couple of things that, Suzanne sent me a text and asked if presenters prefer for us to have our video on or off. So I think we'll just kind of, people feel different about that. So if people want to turn their video off, I think that's okay too. And also don't forget to mute, right? We are all in so many meetings this year where everybody forgets to mute. So if you're not presenting, please mute until you're ready to ask some questions, and we move to that kind of phase of the showcase.
Fabulous, fabulous. So that's kind of how we're going to flow. This is wonderful. We've got 39 folks here. Just want to give a shout out to the Sac State students who are here. Take my little time there. And the Renaissance Society. I see a lot of names there from the Renaissance Society. So just want to throw that out there. Okay, so we're starting a little early, which I don't think is a bad thing. So we're going to kick it off. The first presentation is going to be from Kathy Williams, and she is going to talk about a disease management program that she has been involved with. So Kathy, take it away.
Okay. All right, thank you very much for letting me spend a little time with you today talking about my study. Many disease management programs and organizations that involve change fail. In fact, 50 to 70%. John Cotter, who's an expert on change management and leadership, suggests that for change to be successful, 75% of an institution's management needs to buy into that change. This is vitally important to know when implementing your disease management program in order to have a successful change effort. The Healthy Bones model of care at Kaiser Permanente, Southern California, is the example of the disease management program that was used for this study. Kaiser Permanente is an integrated care delivery system with 14 medical centers. They implemented this osteoporosis disease management program as a model of care in about the year 2004. Let me quickly walk you through their workflow. Their workflow was important to give standardized care across all of their medical centers. It's really pretty simple. Their just-in-time model of care is a one-stop shop concept where everything can be done after the DEXA scan. That's the test that is used for osteoporosis at one time. So they have a centralized workflow used by their Healthy Bones care managers, and they use nurse practitioners and physician's assistants as their care managers. So the patient has this scan for osteoporosis, which is a DEXA scan. And almost all of their DEXA scan machines are housed near where this care manager sits. So sometimes they're literally right across the hall. The patient walks over to the care manager immediately after their DEXA scan is completed. The care manager reviews the DEXA scan results with the patient. The patient is given some education about osteoporosis, calcium, vitamin D, exercise, fall safety. Medication is ordered if needed, and also their blood work or their labs. The care manager documents and codes for this patient, and the patient's provider or physician is kept in the loop. Now, a huge part of their disease management program is capturing the diagnosis and reporting through their electronic medical records. They have a robust IT system. And in their SNFs, their nursing homes, the geriatricians and nurse practitioners and physician's assistants are responsible for this process. At Kaiser, each hip fracture costs them about $35,000 to $40,000. They calculated that they saved one hip fracture for every 100 patients treated and one life saved for every 25 hip fractures avoided. They have continued to see the hip fracture rate decline through the years. The aim of this study was to identify and determine which effective steps to change were and were not present during the implementation of this Healthy Bones program. And this was as perceived by physician champions and the care managers who were working with the program at the time of the implementation in the year 2004, 2005. In other words, what worked and what didn't work at the time of implementation. In this disease management program, the physician champions and the care managers are the decision makers with the greatest potential to use their knowledge, experience, and positions to make changes. These are also the ones for whom the results of this study will probably be the most beneficial. The non-probability sample for this study included all physician champions and all Healthy Bones care managers employed in the Healthy Bones program, each of whom had been employed in his or her current role since the program was implemented at his or her medical center. Out of those, about 12 physicians and about 13 care managers had been working in their current role since the implementation of the program at their own individual medical center. These participants are thought to have played a significant change management role in the implementation of this successful disease management program. Each participant was asked to respond to a set of 9 standard questions. An example of a question was, please describe events, activities, and strategies that you found to be essential to the change effort in support of implementing the Healthy Bones program. So the results of the written responses to these questions were used to develop a set of themes characterizing steps and procedures thought to be particularly effective in support of a change initiative, and those thought to be particularly ineffective or counterproductive. So examples of a couple of these effective themes were rewarding noteworthy behaviors, innovations, and ideas. Another example was creating inclusive feedback systems. Examples of a few ineffective themes were failure to create strong multidisciplinary champions and too much dependence on individuals. Another was inadequate resources and also ineffective or inadequate communications. Data analysis used in vivo, and this is a software package for qualitative data analysis. Some of the managed coding cycles also involved additional coding. So in summary, this study was designed to use qualitative research, depending primarily on computer-assisted personal interviews, consisting of broad general questions aimed at gaining narrative responses, drawing on personal reflections and past experiences. As a result of their interviews, we found what worked, what didn't work, and what they could do better. So as a result, we came up with 10 best practices or steps for implementation of a disease management program. I'd like to take a minute to expand on a couple of these steps. So in step 3, strong multidisciplinary champions, and I can't stress this one enough, especially for that buy-in I mentioned earlier. So getting participants across all disciplines, and this would be as an example from all different types of departments. What they did was they pulled in an endocrinologist, a pharmacist, an OBGYN, an osteoporosis specialist, an orthopedist, family practice, somebody from each specialty. This way, they were focused on an established set of common goals. They shared different diverse ideas, different perspectives, and that way they could suggest innovative approaches for improved services. These multidisciplinary champions are just so important. Another example is with step 6, using technology and outside events and activities. So the Healthy Bones program, they were acknowledged in the Guinness Book of World Records. They tried to be the ones to get the most DEXA scans. This was the test for osteoporosis in 24 hours. And this was a source of pride and motivation and really enhanced the ability for everyone to communicate the benefits of a change effort. They really had fun with this, and it was something that was incredibly rewarding. So the implications for action from the results of this research can be far-reaching. The combination of steps will greatly increase the likelihood of success and long-lasting sustainability of a disease management program. At this time, there are many opportunities for incorporation of disease management programs in many avenues. I feel it's essential that lessons learned from this study can be shared with other healthcare organizations. A set of characteristics have been identified which are necessary for a disease management change effort to succeed. for healthcare reform initiatives at the national, corporate, and medical center levels in the United States and or around the world. The future of disease management programs is vital to every member of society. Without continued attention to this goal, costs cannot be adequately controlled, and quality of life for patients is at risk. I want to thank you so much again for your time this morning. Here's my contact information just in case your questions don't get answered this morning, or if you have further need for implementing your disease management program. Thank you.
Thank you, Kathy. Keep your screen up.
Am I within my 10 minutes?
Oh, absolutely. Yep, you are perfectly.
Good. Good.
Keep your screen sharing, just because sometimes questions refer to a slide, so it's helpful to keep that up until we're done with the Q&A. So now we have some Q&A. Thank you. It was a really great presentation. I'll start with the first question. Do they still hold the record for the DEXO scans?
They do. They do. Yes.
That's very cool. I thought that was
and it was so fun. They had a person come out and give a presentation, and it was quite an exciting event.
Yeah, it sounds really fun. I love that. All right, so we're opening it up to questions. You can either ask by turning on your audio and asking, or you can post in the chat some questions for Kathy, and I will ask those if you post in the chat. And then also a reminder, we'll have Q&A at the end, as have some time to chat at the end. So if you think of a question later that you want to ask Kathy, you can always ask later as well. But we have some time right now for some conversation about Kathy's presentation. Okay, we'll just wait a few more seconds here. And if nobody has questions right now, they might have some at the end, but we want to make sure that nobody has questions.
I don't have a question, but I just want to make a comment. Kathy, thank you so much. I think health promotions is something that we all talk about, but realize that it's much harder to implement than it is to talk about. And so I just wanted to appreciate you sharing your information with us.
Thank you for giving me the opportunity.
Yeah, I agree. I know very little about bone health and these types of this part of health. So it was really interesting to hear a little bit more about the health implementation strategies.
Thank you.
Yeah.
I'll make a quick comment. Kathy, thank you so much for this presentation. When you were going through your presentation here, I was reminded about even things like this being an opportunity for the community and students and higher education to work together. So I think it was Bone Builders. There's another bone program, and we worked with the AAA and my students who became trainers. And so all of these things are opportunities for us to incorporate what we do in the classroom with what we do and what's needed in the community. So. Right.
I agree. And the more awareness we can have about healthier bones and just bone health, and
that's
because
exactly
it really starts younger. Right.
Yeah.
Yeah, great connection, Kelly. Thank you. Okay, well, like I said, we can chat more later if you think of things as we go through the day. Before we get to our next presentation, now that we have more people logged on, we just wanted to make sure that we could all get a chance to kind of get to know one another. So we would love for everyone to post in the chat where, what institution or university or organization you're from. So that way we can kind of just make some connections and see who we have. So please just jump in the chat and let us know where you are from and maybe what your job role is. Are you a student? Are you faculty? What do you do at your job? Just so we can get to know everyone. So I'm doing mine right now. Okay, so feel free to scroll through the chat. You can open the chat box using a link at the bottom of the Zoom if you don't have it open yet, and you can see who everyone is. I know we have quite a few Cal State from different campuses on here. So we'll get to see where everyone's from. Also a reminder, we mentioned this, but not everyone was on the call yet. We do have a Best in Show award today, a $50 Amazon gift card. Thank you to our sponsor. And we had the rotating slides with that information, but we'll pull it up later as well. So we will vote on Best in Show in terms of which presentation you liked the best. So just kind of keep a note, mental note, so that you can vote at the end. So let's see, we got, people, some Cal State. So yeah, just make sure you spend some time making some connections in there. You can also do some private chat. If you see someone that you want to connect with, you can private chat them some information if you want to connect. All right. So we're going to move on to our next presentation. So we have Jesse Archer, who's going to talk about caregiving in quarantine. And I believe, well, I know he's from Cal State Long Beach. So Jesse, take it away.
Good morning. Can you see that?
Yes, we can.
Oh, awesome. So it's my first time sharing my screen. Thank you for having me this morning. I'm presenting my research on caregiving in quarantine, which was published in January in the journal Gerontology and Geriatric Medicine. Huge shout out to my co-authors and committee, amazing Wendy Reibel, Maria Claver, and John Fay. Informal caregivers are everywhere. 1 in 5 Americans are providing unpaid care, and they're often unsupported and unseen. I know a lot of people in my sphere are caring for a parent. I see it everywhere. You probably do too. You may be a caregiver yourself. If so, thank you. They do form the backbone of the US healthcare system, and they are unpaid, an unpaid workforce, mostly female. And I was interested in caregivers because of how they affect older adults. Caregiver burnout is an indicator of nursing home institutionalization, and it predicts, predictor of nursing home institutionalization, and it also predicts elder abuse. As I was thinking about these things, the COVID pandemic hit, and I wondered how that impacted caregiver burden. It fundamentally changed society with these lockdown measures and working from home. And I was just interested to see how burden was affected in this population, especially with this shuttering of essential supports like day programs. And also just the anxiety around your parent, being vulnerable to catching the virus. I was very interested in knowing how burden had changed from before the pandemic to during the pandemic. So that was one of my objectives. And I also was very curious about how family makeup and family composition was affecting burden during the pandemic. So another objective was to compare burden among caregivers of a parent who have siblings and those who don't. And then also how subjective burden in this population was affected between caregivers who were caring for both a parent and a child, and then those who just were caring for a parent. Methods. I recruited 77 informal caregivers of a parent. And that was really hard during the pandemic to recruit people, but I got 77 of them, and I had them take the zero burden interview twice. So they took this interview, which they self-reported their burden from before the pandemic, and then they took it again to report their burden during the pandemic. Those are a couple of questions on the interview. It was the first validated measure of burden. I had them take a short version that only had 12 questions. They are on the Likert scale, and it was self-reported. So that is one of the limitations of my study, is the self-report. I also had them complete a demographic survey asking questions about age, gender, social supports, and presence of siblings or dependent children. Then I looked at both of those sets of scores. So from before the pandemic and then during the pandemic, and I compared them to get results. Firstly, overall, I looked at, I did a paired samples t-test to compare overall scores between the two sets of data. And I discovered we had significantly higher burden since the pandemic in the population overall. I also had significant results when I did a independent samples t-test between those with siblings and those without. So those who had siblings showed significantly less burden than those who did not. Interestingly, those who were caring for both a parent and dependent children showed no difference in burden scores from before the pandemic. So in my questionnaire, I asked about some of the primary sources of burden that I found in the literature and discovered that since lockdown, 46% of my sample reported receiving less social support in the pandemic. Another 43% said it was the same amount of social support that they received. A huge majority, 75%, reported it was harder to navigate healthcare systems. And I found this curious because of the advent of telehealth. I thought that might make it easier. It did not. 69%, another majority, reported their parents' difficult behavior became worse in the pandemic. I did not investigate what constituted problematic behavior, but it is a major factor in that affects caregiver resilience, and it was worse during the pandemic. In terms of family composition, it appears to play a role in caregiver resilience. Siblings appear to buffer caregivers from burden, the primary caregiver, despite 73% of primary caregivers saying they had no choice in becoming the caregiver for their parent. And there's no gender equity here because an overwhelming majority of primary caregivers of a parent are female. But it appears that, at least during the pandemic, that siblings circled the wagons and those brothers helped their sisters. Also, those who were caring for a parent and a child or children showed no more burden during the pandemic. So I wondered if caring for two generations had made them naturally more resilient. They could also be underreporting their burden, or they could be benefiting from intergenerational transfers. The kids may be helping with grandma and grandma may be babysitting kids, things like that. Be interesting future study. Conclusions. My results highlight the importance of family in offsetting burden in the context of a crisis. Another interesting idea for future research would be to see if this happens in normal times, if we have those again. Yeah, so sandwich generation caregivers had no more burden during the pandemic than before. The presence of siblings and or dependent children seem to be a form of social support that alleviates burden. Conversely, those with less family obviously seem to have more burden, unfortunately. Social distancing is not social isolation, but that appears to be a distinction without a difference among caregivers of a parent. Also, day programs and caregiver supports like day programs do not have adequate remote replacements, at least not yet. So developing remote age-friendly interventions to alleviate burden should be prioritized to sustain both informal caregivers and safeguard older adults in their care. Yeah, I was really surprised by the telehealth, that's not making it easier. Thank you very much for having me, and thank you, caregivers. If you have any questions, that's my contact info there. Please contact me. And have a great morning. Looking forward to the rest of your presentations.
Thank you, Jesse. I know we have a question from Caitlin. Caitlin, do you want me to ask? Okay, so Caitlin wants to know, when you talk about siblings, were the siblings of the caregiver or the person that was receiving caregiving?
Oh, sorry, that wasn't clear. No, the siblings of the caregiver. So I wanted to see if they got more support from the siblings, because I would have thought there would be some resentment in being the primary caregiver or that role falling to them, because so many reported they had no choice.
Yeah, a lot of times that does happen where, yeah, one person feels responsible for the parent's care and that the siblings aren't putting in enough support as well.
Not pulling their weight.
Exactly. Yeah. Other questions? Or Caitlin, do you have a follow-up comment?
Oh, I want to monopolize your time entirely, but I won't, because that would be rude. But I had another question, because we're doing something involving telecommunications in older adults. So when you were saying telehealth was not helping the caregiver burden, may I ask how you measured that, or
so I
explain
did
about it a little more?
I used that as part of my demographic questionnaire. I asked just a simple question. So, since the pandemic began, has navigating healthcare systems been easier, harder, or stayed the same? And as you saw, a 75% or something said that it had gotten harder. So I found that very bizarre as well, because how easy is it to just talk to your doctor and get a prescription on, Zoom? So good luck in your work. We need it.
Thank you.
I have a couple of comments and a question for you, Jesse. Thank you for that presentation. It's really great. And to see the Zaret scale being used. So the no difference in burden with the sandwich generation, as you were talking, I was thinking, could quarantine also be a buffer, right?
Yeah.
When you can't be like physically together, you're doing a lot less of the running around, and a lot of us are getting groceries delivered, medications delivered, whatever we can do from our own homes. So I was just thinking if maybe that was part of what you were seeing there, is that quarantine was actually a buffer in that particular context.
I think you make a good point. That's very true. But it could be. It'd be an interesting future study. I think also, because of quarantine and lockdown, and kids aren't able to go out, and I don't know, just monitoring your parents and monitoring your children because they are stuck at home might be easier.
Everybody's just stuck at home, whether you're together or not, right?
Right.
And congratulations on the publication. That's really exciting for you and your team.
Thank you. Yeah, you can read it online. It's open access.
Yeah, they have a great open access. And I'm very impressed about the 77 that you were able to recruit during the pandemic. I've had so many students have to kind of shift gears just because of recruitment issues. So congratulations, great job.
Thank you. It's just as a sort of piece of advice, I got a couple of caregiver centers to do a little blast seeking to help me with recruitment. So if you can find organizations to help you with your recruitment, I think that's a great help.
Is there time for another question, Mary?
Yes.
Yeah. So I thought it was important and interesting, Jesse, that I think it was on the previous slide, social distancing and social isolation. There was no difference in terms of that term. And I think social distancing was an awful term from the beginning.
Yeah.
But, I always say, social or isolation isn't loneliness. Did you look at loneliness, or did anybody bring up loneliness in terms of the isolation piece, even in this caregiving situation?
I did not study that, no. But totally true, right? And also I feel for those without family members, especially during this lockdown time.
Right, because even in a caregiving situation, if it's you and your parent, that could also be very lonely.
Right,
for
exactly.
both. So thank you. It was very informative.
Of course.
And we also have a raised hand from, I believe, Ayesha.
That's correct. Yeah, Aisha. Hi. So I just wanted to kind of comment and ask a question. So I also agree that, back when they called it social isolation, I started changing that. And so I wouldn't cringe. I started, physical distancing and physical separation, just so that the social isolation wouldn't be such a negative connotation for our seniors. But what I did at my office at UCLA is we started this thing called a telebruin. And for those who aren't on Zoom or have computers, which many of our retirees don't, we wanted to have like some sort of phone tree. So we had recruited some caregivers, some students to have this kind of a phone tree. So we would just exchange landlines, or if they had a cell phone number, and just like a hello to check in on people who weren't on the internet. And I think that that's like something that really got us through this past year, because we couldn't Zoom with those who didn't have a computer. And we gave, the volunteers guidelines as to, no politics talk, no cultural talk, just have something light and fun so that people can just engage with someone so that they're not so isolated. And that's something that really worked for us this past year. And since we'll still be home at least until the fall, we're going to do another round of a telebruin, and it was just connecting our retired staff and faculty to other people.
What a great idea.
Yeah, thank you for sharing that. That's awesome. Any other quick
more of that kind of thing, because they can't go to daycare programs and interact with others. So super idea, more of that.
Thank you so much, Jesse. This was a really informative presentation, and of course, very timely. So I'm not surprised you got it published. So congratulations on that.
Thank you.
So we will move on to our next presentation. And let's see, Caitlin wants to connect with you, Aisha, in the chat. So next we have Madeline to talk about age-friendly university. And sorry, I do not know where you're from, Madeline. So please let us know where you're from before you begin your presentation.
Okay. There we go. Okay. Can everyone hear me? Good. All right. So I am from San Francisco State University, working with Amico. Let me go ahead and get this one here. Okay. So we are working on this project called Age Friendly University Initial Assessment, Voices of Older Learners. And oops, here we go. So what is Age Friendly University? So this is an initiative that offers 10 principles to make a university more age friendly, more age inclusive. So this approach helps a university have more inclusivity for older adults to be part of their programs, part of their classes, and just be more involved within a university's network. And so there's an age-friendly university global network. So this is something that is world renowned, so it's worldwide. There are universities throughout the globe that are what are called age-friendly universities. So they're already age-friendly. And so we're trying to have San Francisco State be age-friendly. So it is important to note that we must include older adults in the planning of an age-friendly university. So here are the 10 age-friendly university principles that help to go and be the foundation to be able to identify if a campus is maybe currently able to become age-friendly or is maybe already an age-friendly university. So there are these 10 principles that help you identify. For example, is there something that facilitates intergenerational learning within your university? Is there a community within the university that provides some activities that older learners could be part of the community within the university? So these are 10 principles that help you identify and work towards planning to become an age-friendly campus. Alongside with that, the study purpose of our project was to understand the learning needs of older adults, to analyze how older adults perceive the current university's community in reaching those 10 age-friendly principles that I just showed. And current university, we're referring to the San Francisco State University. And we also gathered and gained suggestions for age-friendly university initiatives within the San Francisco State campus. So these were the 3 purposes that we went through with this project. And the way we went about was through doing some interviews and sorry, here we go. And then Miko will kind of share a little bit of the methods that we did in regards to doing our group interviews.
Yes, so I can cover how we did it. So it was a focus group interview sessions. Originally, it was planned as an in-person meetings. So we reserved rooms and then prepared snacks. And then that was 3 days before the shelter in place took place. So we had to cancel everything and then reschedule all the meetings. And then decided to do it via Zoom. So we did it in summer. So we sent an email invitations to the current San Francisco State University Osho Lifelong Learning Institute. They are located in the downtown little campus space. It's separate from the main campus, but they were going on a very lively Zoom session. So we were able to recruit some participants from this Osho Lifelong Learning Institute. And then we used the auto transcriptions of the Zoom. They're not perfect, but after we recorded the session, so we went back to these transcripts and fixing some of the errors in the auto transcriptions, and then use that as data set. So Madeline and I independently reviewed all the recordings, and then review the transcripts, and then identify some potential themes and issues that were raised in each session. And then we came back together and then discussed what we independently thought about, and then combined our ideas together, just to see what older learners, participants viewed the 10 principles and then how well or not well doing at the San Francisco State. And then we also asked them, to give us suggestions about, how we can go about, because we are really our early stage of the planning and discussing. So we're just trying to get more ideas from them about how we can make our campus more age friendly. So participants, we had focus group interview sessions with 17 OLLI members. 14 of them were females, and then those were self-identified themselves as either white or Caucasian, and then their age ranged from 63 to 86. However, 2 refused to disclose age, so I don't know how old they are.
Okay. So from those interviews and focus groups that we had, we identified 3 themes that kind of kept coming out. We kept identifying from interviewing them and having discussion regarding the 10 principles. So the first theme that we kind of kept seeing and came out was that diversity in learning needs and desires. So we identified that there is a broad spectrum of diversity within their learning needs or their desires. So we saw that some individuals were interested in returning to school or learning as part of the leisure, as part of something that they would like to do as part of their retirement. Others were interested in going back for more stimulation in learning. And then other individuals, you know, they were actually genuinely interested in going back and getting and pursuing either a first degree, a second master's degree, or even a doctorate degree, you know, for a personal goal, or even for actually going back into the world and using that degree as within the workforce. So we saw this diversity in learning and their desires. And so here we have two quotes that we got from our interviews. So the first one of our participants stated, "For me, I appreciate and value my experience with OLLI, but it's more than just engaging in life and stimulation and learning. It's learning and developing ways to be involved and feeling a sense of community." A second participant stated, "I have a lot of energy, and I sometimes think people would get upset when they said, 'Well, now that you have your degree, where are you going to work?' And I said, 'Oh no, I've worked long enough as far as, you know, working goes. It's a personal goal,' because they could accept that." So we see the difference in why they go back and pursue these degrees or these goals of just going back and taking a class within a university level. So then a second theme that we identified is intergenerational learning. So there's some individuals that were hopeful about intergenerational learning, and others were slightly anxious about, you know, being part of an intergenerational community per se. So the majority of the participants were very openly and interested in being part of an intergenerational community. They thought it was a great idea. They loved, you know, they thought that learning from different generations could go vice versa. Them as an older generation can learn from a younger generation, as younger generations can learn from an older generation's experience. Though others had slight concerns of not being accepted because of their age, you know, not being well accepted within the campus community, or in general, just the student body. And so here we have two other participants quotes. So the first one says, "I experienced that intergenerational connection because I was usually sometimes even older than the professor, and I hit a lot of young students, and I really appreciated it for the diversity of what they look, how they look at life, and how I looked at life." So this was coming from one of the participants who had actually taken a class at the San Francisco State University campus. So they had experienced that intergenerational connection within the class. And then the second one, it says, "I do worry about age discrimination and to not be accepted and not being accepted to programs, you know, because of my age." So we saw that open and hopefulness from participants, but then there was also that slight anxiousness or feeling of not being accepted because of their age. All right. And another theme that we also identified was accessibility. And so through accessibility, there were three different accessibility items that we identified, you could say. So the first one was accessibility to information. So how well information was there, or how easily accessible it was for them in regards to being able to find information on community events or campus events, you know, tools or resources for them. A participant stated if there was like one central place instead of having to search all over the map and trying to find out what's available here and what's available there. If there was one, you know, central place that like showed all the different things that were available, that's one thing they identified as an accessibility requirement that they would like for the university to have. So this could be having a direct link on maybe the school's website that has all the accessible, you know, items that they could go and just kind of be a one-stop shop for them. You know, sometimes it is difficult to navigate through universities' websites and identify, you know, if you're looking for a certain topic, they wish it'd be more centralized. A second accessibility that we identified was administration. This is just more so having the process to engage in registration process, or finding classes or getting more information about campus at an administration level. So someone, I stated, my major opinion is they should make the whole registration process easier. And I believe as students, we all might agree to that, finding an easier access. They're getting more information. I think this also kind of stood out. And then the last one was physical accessibility. This is primarily more towards how the campus is located, where it's located. So, this is a commuter school and a very busy area to where it's located. And the majority of them stated that they're used to going to their OLLI classes, but that's located in downtown. It's easily accessible. There's a BART station there they can, walk to get to, versus here they would have to drive. Some of them stated, they take an hour to get there. Parking structure, having to go from parking structure to the buildings. It's a long, way to walk for maybe them, and they feel like it's not oriented. So I do agree with that. As a student that had never been to SC State, it is difficult to get oriented. The school, the campus is just kind of way too, you can say, not well labeled for the buildings. So I agree with that. And, it's around busy streets. There's a lot of traffic at times. So these are 3 items that we found as results regarding accessibility with regards to the 10 principles that when we asked them. And so as a conclusion, so our first steps to consider, we thought we could do or start by doing a small project, something easy, maybe a one-time intergenerational event to kind of get everyone going, get everyone accustomed to each other. Maybe start with a website development to maybe target that one accessibility regarding a one-time stop, with having certain resources be there for them, and kind of fill in the gaps that we identified, as well as maybe assessing what existing resources and opportunities there are at campus. For example, the Career Center, the Alumni Association, seeing how all of these, we can start there, something that's already within campus, and work with them to make it more age-friendly, or reaching out to alumni from SF State. And so that could help us kind of get the ball rolling with becoming an age-friendly university. And then Mika can go ahead and discuss the long-term project.
Yeah, so as for long-term, we thought about, there has to be an effort to change the culture on campus. So one thing that we do have, campus climate surveys, periodically administered, and then the past surveys never really asked anything related to age. So we thought, maybe the next time around that we can, raise our voice and then say that, we need to have more questions related to ageism and age-related questions too. And also some of those anecdotal stories that were shared by participants was related to this, age discrimination experiences, with the staff, when they were trying to call and, find information that, which is really not a good communication experience they had, with, either the staff in administration office, or the faculty, who was teaching the class, or some, some occasions, with students too. So, in the long run, we need to have some sort of cultural sensitivity training so that we can, raise the awareness about this issue. And then that's probably a long-term project we should start working on.
Okay. And so to close off, we have this one statement from one of the participants. And so it goes, and that is the kindness of the diverse student body as a whole. And I know this is just a generalization, but being a diverse urban campus, we have people there from all walks of life, all backgrounds. That is San Francisco State University to me on the main campus, and that's why I'm so happy to be there. So I think that this kind of gives us hope to having San Francisco be a good candidate for an age-friendly university. Just because, you know, someone stated, and I agree, you know, it being a very, very diverse student body, you know, it could help with having be an age-friendly university and having the student body be very welcoming to different backgrounds, different, you know, cultures and what we can say. So thank you.
Thank you so much. That was a wonderful presentation. I love Age-Friendly University, and I'm sure we'll have quite a few questions. So I see Luann has her hand up.
Hi, you know, thank you for that discussion, because I'm a president of an older student organization in Marin County, just north of San Francisco, and been looking at age-friendly university designation. And I have a question. I love your process. First, you know, viewing, you know, what's the views of the older people, and then what are their suggestions? And you really had a great way of looking at the situation. My question too is it necessary to get an actual certification that you are an age-friendly university? In the reading that I was doing, it looked like we would go through these steps and then maybe have to prove ourselves or submit an application to be called an age-friendly university. Any thoughts on that? Is that something you plan to do or feel it's even necessary to do?
So we are trying to be a member, you know, but one thing I think is the benefit, and I think, you know, some other, because Long Beach has been already been certified as a you know, the age-friendly university, a global network member. But one thing I think is that, you know, we can accomplish by becoming a member is that it has the, I think, a campus-wide support, you know, you know, to create the momentum, you know, to for the actions, you know, to roll out some of the, you know, events and then, you know, efforts, like the climate, you know, campus climate survey, you know, because to become the member, you have to have the provost and president's support letter, right? So that means that you have this, you know, really administrative support, you know, for, you know, all the activities we want to do. And also it's a really good publicity too, because, you know, you get to, you know, present that on the website. So I think there are a lot of benefits to become a member. At the same time, so there are so many things you could do in the meantime. You know, I think for us, you know, on our campus, and it's been a little frustrating, you know, to get to even the point, you know, to have the letter, you know, from the provost because of all those, you know, I think disruptions in the pandemic. But, you know, hosting an event, you know, intergenerational event in the meantime, I think it's something that we can do, you know, while we are working on, you know, becoming certified as an age-friendly university too.
Great, thank you. It's really been helpful for me to listen to your talk. I appreciate it.
Mm-hmm. I think Maria might have a comment because we are certified at our campus. Did you want to comment on that, Maria?
I do, and thank you so much for that comment. So certainly designation as an age-friendly university doesn't mean that we have all 10 principles wrapped up and we're perfect, you know, boxes checked. It's more of a declaration, a public declaration that the university is very interested and dedicated to the improvement, continuous improvement to making the university age-friendly. Certainly an institution doesn't have to be designated to do the work of becoming age-friendly, but I find that networking with the international group of universities, being on that list, like Amiko said, certainly is good publicity for the university. It also puts the rest of the university kind of on notice that, hey, this is something that the upper leadership of the institution is invested in. So I think it gives our smaller efforts more credence, just to have that support from the president and the provost and so on. And it's really nice to just belong to the network. We do a lot of bouncing ideas off of each other. In terms of the being judged or having to go through hoops and things, now is a fantastic time to join Age-Friendly University because those standards are still in development. University of Massachusetts in Boston is doing a lot of work in Long Beach is one of the universities of many that is participating in their national research to establish more rigorous standards. So I think in the future, designation as an age-friendly university is going to become even more strict, perhaps even have a fee attached. Maybe you'll have to go through more rigorous evaluation. So get in on the ground floor now is my recommendation. Also, Emiko and Laura Zettel-Watson are our CCGG CSU reps. And I know that we're going to be doing some work, not just for the CSUs, but for anybody interested that's a member of CCGG. We want to actually pull together a workshop of sorts so that those of us who have been through the process can mentor other institutions that want to go through the process. So please consider joining CCGG membership so that you can be invited to that. And then I can also put my email in the chat box in case you want more information, since we were designated in 2018. So happy to talk a little bit more.
Thank you. Great, Maria. I will look for that. What school are you from?
Cal State Long Beach.
Okay, great. And I'll look for your email and get in touch. Thanks so much.
Sure. Thanks for the question and interest. And great job, Emiko and Madeline.
All right, so I want to make sure we keep rolling, but we do have one quick question or comment from Lorenda, and then we'll move to our next presentation.
Okay, so I'm glad Maria clarified that it's not like this. It's not like getting accredited or something like that. It's a very simple process, and it's an engagement rather than a certification. But I wanted to comment on how ageism impacts students in the classroom and to kind of put that on your radar as well. So I originally was going to be a speech pathologist and experienced so much ageism as a student at 54, right? That's when I entered community college. By the time I got when I went to university, I just hit so much ageism within the classroom that it became my interest area and my area of research. And I shifted to gerontology to be able to do that. So it really is a problem in the classroom as well as on campus. And learning about the learning process, the cognitive processes of learning and how it differs in older adults is really important to faculty, because there is now kind of an older student stereotype, a negative older student stereotype, and it is a response to the differences in the learning processes that older students who have all kinds of experience packed into their brains, it's a result of what they go through when they learn. And so we want to kind of keep that in mind, and I can share more about that at some other point in time. So that's it from me.
Thank you so much. And there's lots of good contact information in the chat. So if you're interested in AFU contacts, make sure you grab those from the chat. We're going to roll right along to make sure we get through everyone today. So next we have Tasha Clark from CSULB, and she's going to talk about funeral pre-planning.
Okay, here we go. Hello, everyone. Thank you for CCGG for this showcase opportunity. I would also like to acknowledge Dr. Maria Claver and Dr. Mary Marshall from the CSULB Gerontology Department for their continued guidance and support on this project, for which I am grateful. Let us look at the emotional, social, financial benefits of pre-planning funeral arrangements, a 3-week training. The background, what is pre-planning? Pre-planning is an arrangement that makes an individual who's making that before their death, involving planning the nature of the funeral they want and the components involved in the process. There is evidence about the significance and the importance of pre-planning for one's funeral in advance. Planning a funeral for a family member can be emotional, complicated, and costly. The necessity of such arrangements before death continues to grow, with the American population aging progressively, terminal illnesses becoming more prevalent, and the recent emergence of a global pandemic. Funeral pre-planning is not a priority, or it is too costly, while others say they have not thought about it, according to Shang, Simpson, and Sigwa of 2019. Such planning is also important because it eliminates or minimizes disputes or uncertainties, reduces pressure and stress among the family members, and helps keep the memorial services within budget. When people pre-plan, the path is clear for all to follow. Improving the awareness and acceptance of pre-planning may improve end-of-life experiences for families. The growing older generation who has greater acceptance and the concept of death and preparing for it, and more resources to support this plan. The objectives state that this project is aimed to create a 3-week training about the value of pre-planning final arrangements for both facilitators and older adults, and it provides participants with basic introductory knowledge on pre-planning. It creates informative and interactive exercises to empower participants to make informed decisions, understand the value of pre-planning ahead of time, and create a framework that can be discussed with family to ultimately assist with finalizing their arrangements while they are alive. With the methodology focused on quantitative analysis, it assesses the appropriateness of the training program before dissemination. Expert reviewers from geriatric healthcare and end-of-life care fields offered insight on the curriculum and program overall on course objectives, clarity of assignments, and structure of worksheets. The experts used 12 aspects captured by open and close-ended questions to assess the program. The report was then used to improve a 3-week training program targeting adults ages 55 and older. Most adults in the United States have very limited knowledge on pre-planning for final arrangements. The concept must then address the current inaccessibility and the inadequacy of public information on the topic. The process must also integrate adult learning for older learners. Adult training methods and the delivery of instructional materials will include the use of physical and virtual training platforms. Microsoft PowerPoint will be used to make appealing graphics and as a form of presentation to the participants. Adult learning utilizes certain techniques as it is goal-oriented. Adult learners need to find a reason for learning that often applies to their life situation. The high probability is that learners' assumptions could change depending on what they learn from the training. Participants will be provided with 1, basic knowledge on pre-planning for final arrangements, 2, informative and interactive exercises using adult learning theories of andragogy and transformative learning. Ultimately, they can finalize their final arrangements and tell families about the process. Here is the expert reviewer feedback form that was used by the expert reviewers to compile their results. There are questions A through L. This will help you understand the results and analysis. Just for example, the letter A would be the question on based on the PowerPoint slide, course objectives are clear, B, content is presented clearly. Moving on to results analysis. Continued. The Likert scale assessed 12 aspects from the expert reviewer's point of view. The scale asked the reviewers to share what they like most about the program or the curriculum and what suggestions they have for improving the program, from strongly disagree to strongly agree. A, B, and C, the context and content approach was appreciated by one reviewer stating, quote, the information was spot on for the topic of death, unquote. The training material averaged a score of 4.89 out of 5. D, E, and F, there was a positive response in one reviewer regarding the use of assignments and learning exercises. Questions D and E elicited the remark that, quote, the discussion was very helpful for older adults, unquote. The topic of death and pre-planning received approval with prompt F averaging 5.0, Question G, the need to ensure the content builds the value of pre-planning as a life option, was listed as a central necessity of the training process. H, the printed materials, additional references, and the overall structure of the curriculum received positive responses at 5.0. For IJK, it concentrated on the clarity of the objectives of the material and the presentation of the training content, scoring on average 4.73. L, all reviewers strongly agreed that the materials were able to capture the concept of the program, the quality structure of the curriculum, and its worksheet scoring 5.0. The reviewers gave an average total score of 4.90 out of 5 for the presentation and organization of the content, its compilation, intended delivery methods, the auxiliary functionality, and the facilitators and notaries in the process. Results and analysis continued. Expert reviewers offered some insightful comment results on the curriculum and the program overall. There were also a couple of recommendations. Having the option to meet this notary is a really nice touch. I've never heard of this before. The cost of services were eye-opening and why it is important to be prepared. I really like that there were important checklists that the participants can learn about, work on in the training, and then take away to use them in the planning. These documents are very key to a successful planning process. The activities that involve group discussion seem to be very helpful for older adults to understand and guide them to achieve the goal of pre-planning for their funeral. I like the overall content. I can see why people need to know this information. I'm always for the military as I come from a military family myself. Great job on the information. This was extremely helpful. The information was spot on for the topic of death. And the recommendations, there were just a couple. A closure slide would be helpful to pull it together, the objectives learned in the activities and how they relate to pre-planning, and explain a little on the PowerPoint page what the advanced directives, etc., are, and the differences so that they can be used by the participants later. Moving on to conclusions, implications, and recommendations. For the conclusions, it is an eye-opener for most people who have never thought of planning for funerals, especially while living. The most significant benefit of pre-planning is the financial aspect, which can be overwhelming to family members. When one dies, the people left behind are less likely to be prepared enough to handle the situation. They may not know what to do or next or who to turn to for help. Pre-planning allows one to document one last wishes, and it is important because it eliminates, minimizes disputes or uncertainties among family members. The implications are when participants have adequate information, they are likely to start thinking of taking necessary small steps to make the event less burdensome. When participants attain the desired behavioral changes, they are more likely to think of pre-planning for their funeral arrangements. They would also influence others to start thinking of planning for their own funerals. Succeeding to changing the attitudes and beliefs of the participants would be a significant step towards planning in advance. Unlike normal situations whereby consumers seek the services and products urgently, and thus they are vulnerable to exploitation, early planning gives consumers more power to bargain for services and products. Lastly, the recommendations. It is advisable for everyone to pre-plan for their funeral arrangements. Gains from the program could be used in the improvement of the implementation of end-of-life planning as a whole package. Further research may evaluate more formally how the combination of such services would not only reduce the amount of documentation for the applicant, but also the simplification of processes such as funeral pre-planning, estate planning, and end-of-life care. This program has made it possible for the integration of the conversation of death and the planning that surrounds it, which opens up avenues for a formal evaluation of the effectiveness of such planning. For such evaluation, it would be necessary to consider the value of the program, the reception by different communities, and the challenges that face both applicants and their survivors in the event of a funeral. It doesn't matter how old you are. My question to you, do you have a plan? Thank you.
Thank you so much, Tasha. I know I was on her committee, her thesis committee for this project, so I've already asked her a lot of questions. So let's see what other questions we have. I see Donna.
Tasha, that was fabulous. I'm very interested in end of life and did some research on advanced care planning. And one of the things that the big question that I have that I don't know that I think we need to answer or find a solution to is, you know, we do all this life planning. We plan college, we plan marriage, we plan where we're going to live, we're planning kids. We don't plan our death in terms of like preparing for it. And so I would love to see that as included in just a developmental life piece, just how you evaluate whether or not you're going to have kids. So I appreciate your work that you're doing. My question is, in terms of the people that participated in this, was there a mix of cultures or ethnicity, race, in terms of, did you see any difference in the willingness to have those discussions based on any of those demographics?
Actually, no, that would be another part or an addition to the study. It was actually the expert reviewers who were doing the capturing of the results. They were really focused on the curriculum itself, just make sure that it would be feasible to offer as a program to participants in the future, to see that if they wanted to take a class on it, basically to learn how they can prepare a framework while they're living, so that all of that will be completed. And so when they do have to enter that next realm, they would have that information already for their family members to take a hold of and move forward with.
So very much needed. What is are you planning to like roll this out to the population, and what's next for you with this?
Well, that's my plan. I would definitely like to offer this as a program or a class to be taught within the community, to just to see, at least for the first time, to see how it will do. I'm hoping that it will do well, because again, it's a topic that we just don't talk about. We forget about it. We don't want to even think about it, let alone. But if we can start planning for this, it just makes, you know, life easier for the ones that are left behind, because again, they're the ones that are kind of put in that situation where it's just completely stressed. They may not know what your wishes are, but at the same time, they will have a plan in place, and then it will be according to what your wishes are. And that's what is important, is to be respectful of that.
Great, Tasha, I have a question and some comments. When Donna was talking about, we don't plan for our death, many of us don't plan for our aging either, right? So those two things are intricately linked there. In terms of rolling it out, so Donna stole my question there. That was what I'm really curious about, how you plan to use this. I know we all love to see our students who do project-based work and research, you know, bring these things to life. And what I was thinking about was our resident attorney on our board, the CCGG board, is Maribel Zielcita, who also is sponsoring the $50 Amazon gift card today. She is an estate attorney, and I couldn't help but think that this is also so helpful in so many different ways, on an individual level, on a learning student level, and then also on so many different community, in so many different community contexts. You know, people did planning and were educated about it. Yeah, it's really great work.
Oh, thank you very much.
I see one question in the comment box that says that someone had a thanatologist visit their class, and wondering if you would bring in some type of speaker like that in your program.
Yeah, that would be actually a great suggestion. I had developed the curriculum for the 3-week training, and within that, I did not have a speaker series or someone that could be brought into that, but that is an excellent recommendation. I can definitely weave that into that, because I think that's very important. Thank you for that.
Tasha, I just wanted, thanks for that question or comment about the thanatologist. I don't know if you know about them, Tasha, but the ADEC, the Association for Death Education and Counseling, this is really great work that you could bring there to present, actually.
Okay, that'll be good. Thank you very much.
Yeah. I'll put them in the chat. I'll put their contact in the chat.
Okay, perfect. Thank you.
Thank you so much, Tasha. We're going to move on to our next presentation for time. So thank you again. So next we have our presentation from Caitlin, and she's going to be talking about fibromyalgia. So again, Caitlin, I think you're from CSUF. So go ahead and share your screen and tell us a little bit more about your project.
Absolutely. Can everyone hear me okay? Awesome. Hi, everyone. Good morning. I will be doing two short presentations today because at least one of them will be because I have a colleague coming right after me, and I figured it would just be easy to get an overview of the lab in general out of the way before we do both of our posters so that people can understand a little bit better, if that's okay. So here is a quick overview of our lab at Cal State Fullerton. So our lab is called the Fibromyalgia and Chronic Pain Center. My name is Caitlin. I am an MA psychology graduate now from Cal State Fullerton. I worked with the Aging Studies academic program for a couple years. I have been lab manager of the Cal State Fullerton Fibromyalgia and Chronic Pain Center for a bit as well. And basically what our center does is it conducts research to educate, promote awareness, and generally help people with fibromyalgia and other chronic pain conditions. Oh, I have a couple things in chat. Oh, I can't see chat while sharing. I hope everything's okay in chat.
There are questions from, or there are comments from the last presentation. You're good.
Okay.
I'll let you know.
So thank you. So what's fibromyalgia? Fibromyalgia is present in 3 to 6% of the worldwide population, although that does change depending on where you are getting your data from. It includes widespread chronic pain, fatigue, memory problems, sleep disturbances, and mood disorders. And it has a host of comorbidities that go along with it, including irritable bowel syndrome, headaches, temporomandibular disorder, among other things. When it comes to diagnosing FM, it's very interesting because it has changed a lot in the last 30 years. It was first diagnosed in 1990. It first had its initial diagnostic criteria in 1990, and since then it's been evolving a lot. It's a fairly new disorder when you're looking at it, and the etiology is not clear. It's hard to diagnose and treat, and the current diagnostic criteria is a combination of a bunch of different criteria from the past 30 years, because some things work better with doctors, some things patients understand better, and people are just using different things to diagnose. It does occur in the younger population, but is most diagnosed in older women. And again, this is just an overview of the Fibromyalgia and Chronic Pain Center because the next two presentations will be on this. We are done running participants. We have 10 years of longitudinal data across dozens of new variables to analyze. I will be presenting next on my poster on depression, FM status, and cognition in older adults. And then Melina will be right after me. And she will be speaking about her poster on affect in older adults with fibromyalgia. Okay, so fibromyalgia out of the way. Just wanted y'all to know what that was since the next two posters will be talking about it. And then let's talk about my poster in particular. Hi, everyone. My name is Caitlin. Nice to meet you again. Okay, so my poster is on depression as a mediator for fibromyalgia status and cognitive functioning in older adults. I'm presenting this poster on behalf of myself, a grad student, Dylan Serpis, Maria Malone, Warren Wells, Sarah Fabian, Dr. Barbara Cherry, Dr. Laura Soto-Watson, and Dr. Jennifer Trevitt. We are from the Departments of Psychology, the Aging Studies Academic Program, and the Fibromyalgia and Chronic Pain Center. I've already discussed what fibromyalgia is, so I'm just going to zoom in and start talking about depression and fibromyalgia, if that's okay. Okay, so reminder, fibromyalgia is a very prevalent chronic pain condition. It is characterized by mood disorders, changes in cognition, and decreased in physical functioning. So how are depression and fibromyalgia related, commonly referred to as FM? And I will probably be talking about it as FM for the next little bit. So what are depressive symptoms? Depressive symptoms are an array of cognitive, affective, physiological, and behavioral symptoms that negatively affect the way people think, feel, and act. How are depressive symptoms and FM status related? Well, FM status is predictive of depression. Depression is also predictive of FM status. It has a bidirectional relationship. FM patients with depression also often report more pain and other symptoms, including issues with more cognitive functioning. So how is cognitive functioning related to FM? Cognitive functioning in this scenario references the mental abilities involved in knowledge acquisition, manipulation of information, and reasoning. Cognitive function is related to FM status in that those with FM tend to have impaired objective and subjective cognitive functioning when their symptoms are very bad, and they experience something called fibro fog, which has to do with difficulty in concentrating, as well as semantic fluency, working memory efficiency and capacity, executive functioning, and decision-making. So our hypotheses for the study were that depression would mediate the relationship between cognitive functioning and FM status. We found, let's go back to the top. In our sample, we had majority female sample, 82%. Our age range was between 50 and 87 years old. Majority of our sample did not have FM, and our ethnicity was mostly white. So our data analyses, we focused on secondary cross-sectional data from 2008 to 2014 with 4 waves of the fibromyalgia longitudinal study. The cognitive data included animals for semantic fluency, digit span, forward span for working memory efficiency and capacity, everyday problems test for executive functioning and decision-making, and the Beck Depression Inventory for depressive symptoms. We used a combination of those with fibromyalgia and healthy controls, n equals 222. And we used asymptotic mediation analyses using the process macro. I would like to thank Statistics of Doom on YouTube for their amazing use of mediation analyses and their step-by-step look at mediation by Hayes. They're just a delight. So for our results, what did we find? Individuals with FN had poorer cognitive functioning, unfortunately, with depression as a partial mediator. There were no mediation confidence intervals, which contained 0, which is good. All syllable tests were significant, also good. FM participants had more symptoms, which is good for our analyses and our hypothesis, but bad for those with FM. And those with depressive symptoms had lower levels of cognitive functioning. And you can see all of this in these pictures up here. If I can go up high enough. So this is semantic fluency, and again, semantic fluency with animals. I'm sorry, my dog is like so upset about the wind outside. Working memory efficiency and capacity was digit span, forward span, and you can see all the relationships here. Executive functioning and decision making, again, all the relationships here. Confidence interval did not cross 0. And then for our conclusion and future directions, I just wanted to bring up, this is consistent with past literature. Unfortunately, there are objective cognitive declines frequent with FM patients, and those are related to depressive symptoms. Mood matters. And this may also help those with long COVID, for example. In the past, or just recently, so long COVID is a new condition that people may get when they've had even a mild case of COVID-19. And some of the symptoms that they are exhibiting include depression, difficulty breathing, coughing, of course, but also brain fog, like we see with other myalgic conditions like fibromyalgia. So I do think that our results could in some way help those with long COVID, in that if you treat the depressive symptoms of fibromyalgia and other myalgic conditions, you can help the physical symptoms as well. So we need to be looking into the mood issues with long COVID patients and be taking care of them in a psychological way as well as a physical way. Okay, I know that was a little long. There's a lot of information. So thanks for staying with me. Does anyone have any questions? Thanks.
Thank you so much. It's very interesting information. I know we're going to learn a little bit more as well. I kind of was bouncing around between some administration tasks. So let me know if you already answered this question. But when we as a team were looking at your presentation, we were curious what you meant by animals. Do you mean like, is that a cognitive test about like naming animals?
Yes, it's listing animals. How many animals can you list within 60 seconds? And then you sit there and then you record the participant as they speak. And we chunk it up into 15-second intervals. And within the first 15 seconds, you list them as fast as you can. And then the next 15, the next 15. And then we have all of that data as well as the backup recordings.
Okay, because I teach like Alzheimer's and dementia courses, so I'm aware of like the MOCA where you're identifying animals, but this, they can name any animals that they can think of on their own.
Yes, any animals that you can think of within 60 seconds, and we try to ask them not to do repeats. So like if it's polar bear and bear, that wouldn't work.
Okay.
Yeah.
We were like, yeah, just wondering what that was. They're very cool.
Sorry.
No, it's okay. I think testing is very interesting.
It's super cool.
Other questions for Caitlin?
I have a question. What about koala bear? Does that, no, I'm kidding, totally kidding. My question is, and I may have asked this last time, Caitlin, too. It seems like, and your research shows that the majority of FM folks with FM are women. So, and it used to be back in the day that it was just kind of a diagnosis they'd give people who were kind of pain, no pun intended, in clinicians' rear ends. I'm wondering, in terms of the research over the last 30 years that you guys have been doing this, are you seeing that there is a genetic component to it that predisposes women to it? Or is it still kind of this, how the symptoms manifest, we more aligned with women, women's behavior and stereotypical things about women?
So from what I've seen, and Dr. Zittel Watson may be able to help me with this, but from what I've seen, there is no particular genetic component. If there was, we would be able to help people a little more, I think. But as is, it's actually interesting because Wolf did a study. The guy who first came up with the diagnostic criteria for fibromyalgia pretty recently, like in 2018. And he spoke about how in an unbiased situation, when looking at diagnostics for FM, the diagnosis of males versus females is actually the same. So we're on this whole project right now in fibromyalgia in our lab specifically to go through and like correct Wikipedia and the Arthritis Society of America and all these other places, because they are saying that women, while they are getting diagnosed more, it is not necessarily more prevalent in women. They're also seeing that with long COVID, I think, from what I've seen recently. They're getting diagnosed more, but it may not necessarily be because they have it more often. Yeah.
Interesting, just that gender bias, right? In
yes,
our diagnosis.
Exactly.
Yeah,
exactly.
Thank you. Other questions? Thank you so much. Well, we'll roll right into our other fibromyalgia presentation, and there might be some more questions there at the end. So I believe we have, oh wait, we do have one question really quickly. How was an ethnicity arrived at?
So we had a multiple choice question that had multiple different, it was like a fill in the blank, which had white, Hispanic, African-American, Asian, Indian, Pacific Islander, stuff like that, and other. And then people went through, and multiracial, of course, and individuals went through and checked off a box or wrote in the other category.
Great. Okay, so we'll move into Melina, who's also going to talk about fibromyalgia. So you can share your screen. Thank you.
So can you hear me? Somebody? Yeah, awesome. Thank you. So good morning, everyone. Thank you so much for letting me present the poster that we, Jenny, Don, Chris, we call him Chris, Kian, and Matthew, Dr. Cherry, Dr. Sarah Watson, and Dr. Trevitt created for you and for other presentations. The name is Affect Balance Predicts the Experience of Pain in Adults with and without fibromyalgia. As Caitlin already explained, fibromyalgia is a syndrome which is characterized by pain and muscle stiffness across the body. It has a lot of symptoms, multi-symptomatic, and it's been associated with depression. Also, relevant to this particular study, we find out that fibromyalgia is associated with low perceived physical function. In addition, we find in the literature that affect balance is associated with pain, both physical and mental. Affect balance we refer as the overall emotional well-being, which incorporates both positive and negative affect or emotions. Therefore, our hypothesis is affect balance predicts pain intensity, pain interference, and composite physical function, which I will explain a little bit later. The number of participants that we considered for this particular study was 122, with an age range between 50 and 93 years old. The median age was 67 years. 81% of the participants were female. 67 of them were diagnosed with fibromyalgia. Now the variables are pain intensity, which was assessed, everything is self-assessed, by asking in a paper inventory the average of their level of pain within their week. And the scale was from 1 to 10, where 10 was the minimum, or slightly not at all. 10 was maximum unbearable. The second variable is pain interference, which was assessed almost the same, but in this case, it was how much their pain limited their ability of perform daily activities. Daily activities we divided in both activities of daily living and instrumental activities of daily living. Activities of daily living, as pretty sure everybody here knows, is bathing, dressing, eating, some basic self-care. The instrumental activities of daily living is a little more complex, such as cleaning up, driving, making a call, etc. Our next variable is the PANAS inventory. PANAS is an acronym from positive affect, negative affect, schedule. This is an inventory of 20 emotions or feelings in which in the top it does indicate the way to what extent you feel over the last week or right now. And is something in the chat for me? No, okay. And we have the list from negative and positive emotions. So positive emotions are like happy, active, and focus, etc. And the negative emotion was more like afraid, nervous, ashamed, etc. So they rated from 1 to 5, where 1 was slightly or not at all, and 5 was extremely. So we ran some statistical analysis. The first one was a t-test to compare the difference between people with fibro and people without fibromyalgia. We find out that there is a significant difference in pain intensity, pain interference, perceived physical function or CPF, negative affect, and affect balance. However, it makes no difference for positive affect, which remind me, I forgot. So the PANAS inventory, we sum up the positive affect and the negative affect, and we make, positive affect minus negative affect so that we have the final affect balance total. But when we separate those two emotions, positive affect make no difference whether or not the person has fibro. We run also correlations, and we find out that all the variables were correlating among each other, and they affect each other. And as Caitlin said, some of them, they were bidirectional. Finally, we run several regressions, and after controlling for age and FM status, we find out that affect balance was a significant predictor of pain intensity and composite physical function, but it did not predict pain interference at all. That is, emotional well-being reduces pain, increases perceived physical function, but it doesn't affect pain interference. As a conclusion, patients with chronic pain need non-medical strategies and treatments to treat their pain in addition to medication. Thank you. And if you need to contact me, there is the contact below, but I'm also putting in the chat room right now.
Thank you so much.
Found it.
Thank you. This is more of a comment. I talk about activities of daily living in my classes, but I've never seen that there was a measure, the composite of physical function inventory. So that's pretty cool that there's actually a measure that involves that. So I'll have to look into that when I'm teaching my classes. So thank you for making me aware of that.
Yeah.
So I have a question. So I wanted to learn a little bit more about what you think about non-medical interventions. So let's say that somebody is sort of emotionally struggling. What would you recommend as an intervention?
Well, in this particular study, we were talking about affectivity, like emotions. And several studies recommend to have either it wasn't a thank you. It was forgot the name. When you journal, like things that happen, positive that happened today, like focus on the positive rather than negative, that actually help to reduce perceived pain. And basically that's what we were talking about. At least Dr. Sherry has something else to add. That's all that I can remember, that we actually talk about this, that my conclusion was, well, being happy and positive takes work. And she was, yes. So maybe if we work a little bit more on our personal effects, it will actually help.
Yeah, certainly.
Does that answer your question somehow?
Yes. Yeah, I think a positive attitude, and then I think if we can encourage that, that can make a really significant difference. And I agree with that point. Thank you.
Pleasure. And as a side note, I remember a few studies that people with depression have a higher perceive of pain. So if we're depressed, we're not particularly happy. So maybe that may mediate as Caitlin says so.
Thank you. Okay, so Caitlin just added a comment that the composite physical function scale was created for those with fibromyalgia and adapted from a physical activity inventory, and someone from their lab actually helped develop it. So that's super interesting. Thank you. I love hearing when we have people we know creating these things that are used. Very cool. Any other comments or questions on the presentation?
I posted something, just curious, Melina or anybody from your center. Are you guys doing any studies on CBD related to the pain or impact of fibromyalgia?
Not that I'm aware of. Caitlin, CBDs?
We would love to, but we have about 10 years worth of data that we still have to get through. And I think our lab made a pact to not collect any more data until we analyze the stuff we already have. But we do have some really interesting stuff. Unfortunately, a lot of our data is from the before times when CBD and other such things were not legal yet. But we do have other medications that we will be able to analyze. But yeah, that would definitely be a super interesting story. And I've heard lots of anecdotal evidence that it helps quite a bit, especially in terms of inflammation. But yeah, just not at this time.
This is Laura. I'll jump in here to just let you know if you are interested. Our lab is not doing that right now, but in the last few years, especially since wider legalization, you can find so many good research articles on both topical CBD oil as well as ingested forms of THC and marijuana and things for pain control and maintenance. So lots of information out there. If you are interested, I'll put my email in here and you can contact me and I can give you a couple places to start looking.
Thank you.
Thank you.
Awesome. Well, thank you to all of our presenters. You all did wonderful today. I think we all learned a lot. I'm going to throw it over to Amiko, who's going to talk a little bit about our Best in Show Award. And at the same time, I'm also going to share the screen here really quickly so that we can thank our sponsor for sponsoring our gift card for our Best in Show. So thank you so much to MMZ Law. And Amiko, you can explain the Best in Show Award.
So we decided to do a Best in Show Award. Just generally speaking, that listening to all those presentations, what was the most favorite one you had? There's really not a really formal criteria you have to go through and think about. But just pick your favorite and then enter your poll. So I believe Donna is going to do the polling.
Yes, it is open and it's anonymous voting. So take a minute and cast your vote. And while that's happening, we also have Amiko, a survey, right, that we'd like folks to give us some feedback on this process.
Yeah, so I'm going to share a link in the chat box. So if you after you finish voting, if you can click this survey link and then answer a couple of questions about what you thought about our event today, that would be great. So I'm hitting the chat now. This is the Survey Monkey link.
Yeah, as I said earlier, we want to continue this. It's such just a refreshing a couple of hours just to hear what's happening around our state in terms of aging research, research on aging.
Hey, Donna, have we, correct my memory, I have sabbatical brain right now. Do we have a date for our fall showcase, or we'll be working on that and get a save the date out for everyone?
We'll get a save the date out, yeah.
Okay, all right, great. And then I know that Maria, Dr. Clover will probably talk about this too, but going back to the age-friendly universities project. We do have quite a few people on our board working on a working group. So there's a number of things going on there, and Mary Marshall is kind of heading that up. So if you are a CCGG member and want to be part of that working group, she's the person to get in touch with. I think we'll probably have some information on our website as well.
All right, so we've got about, looks like 7 more people. If you want to vote, consider this your countdown. 10, 9. Oh, it's close. If you want to vote now, you get your vote in. 1 vote can make a difference. All right, 5, 4, 3, 2, 1. Okay, so I'm going to end the poll there. Our winner today is Jessie Archer with Caregiving in Quarantine. So congratulations, Jessie.
Stop it. I'm so surprised. Thank you so much. That's very kind of you all.
Yay. So you get $50 to deal with the devil at Amazon. And
that's awesome. I should split it with all my other presenters. You guys were amazing. Thank you.
So Donna, Maribel had to be in court this morning, but she joined just in time. So our sponsor, Maribel Zielcita, is on here. So shout out to Maribel and congratulations, Jessie.
Yes, we do appreciate the sponsorship, the generosity, Maribel, of you and your law firm. So if you need any estate planning or consultation, consider MMZ Law, because they're a professional corporation. But no, a big supporter not only of this Best in Showcase Award, but also on the CCGG board. Fantastic. So now I think we are going to throw it over to Maria, right?
I am wrapping this up.
All right.
Thank you all again. And to the Education Committee, another flawless showcase. I really have enjoyed the ones that we've done. So stay tuned, everybody, for our fall showcase and possibly for a few other things in between. As was mentioned, our Age-Friendly University subcommittee has been brainstorming some ways that we can be of support to anyone else interested in that topic. Jessie and I were actually doing some chatting privately about another idea we have for a possible gathering. So stay tuned for those ideas, and congratulations, Jessie. So proud of you. And Tasha as well, that I've worked with both of you and you're so fantastic. Just as a reminder, we have recorded this session. So if you know of someone that you think would benefit from the recording, we'll make sure that we post that. And as Kelly, our president, was mentioning in the introduction, you know, this organization has gone through a major overhaul. There's so much passion and creativity that has gone into reimagining what CCGG is all about. As a reminder, our focus areas are workforce development, education, and advocacy. So if those are things that are important to you in the state of California, we need you. We would love to have you join officially our organization. So there's some information on the slide right now as to how you can do so. When you officially join, you are joining the ranks of those of us that when we go out to advocate or when we go out to speak up, we can say our membership is X number of people strong. And we really are inclusive. Students, academics, professionals in any field that has to do with an interest in aging, practitioners, business people, retirees, community members, all of the voices are so important. So that's my little like telethon of membership. We will be creating different membership opportunities and perks for our paid members. So please just kind of follow us on one of our social media. Let me know. You can always email me. Again, I can put my email address into the chat box once again. You can just email me and I'll make sure you have all the information you need. So again, thank you for joining us today. To our presenters, congratulations. Keep up your great work. You are always invited to come back and present upon what you're working on next. So please keep us keep us in mind, and we hope to see you at our next event. Thank you all so much.
And Amiko, did we get the link posted to the survey?
Yeah. I will.
Okay.
Once more.
Oh, there it is. Yeah, do it once more. So we hope that you do take just a couple of minutes to fill this out, to give us some feedback on how we can improve this, what we're doing well, and maybe some ideas. We know there's creativity in numbers, and the more feedback, the better. Now we just kind of have time. We're going to leave it open. If there's networking, if there's more questions, if you want to connect with each other, this is just an open time for all of us. So if you want to hang out and chat, let's do so.
And I'm just going to throw, I'm going to put the slides up, go through the slides one more time if anybody wanted to grab any information from our rotating slides. So I'll leave that up for a minute while we kind of chat a little bit, and then you can get any information you were wanting from that.
Well, while the robust chats are getting formulated, I'm wondering if the folks, we've got several past leaders of CCGG here today, and I'm wondering if you guys can just say hi and introduce yourself, because I think it's important that we always honor our history.
We're all shy.
I know, right?
Do we have to call them out?
I'm going to call Pauline out.
There you go.
I think Pauline's still on. Let me check.
Thought I just saw her too.
Maybe she jumped off because she thought we were going to make her speak.
No, yeah, she's off. Well, it's also because, it's still her birthday week. Yesterday was her birthday.
Maybe Jesse and I could share with you the idea that we had for another CCGG event.
Yes, please do. I've been thinking about it ever since you said that. It was such a teaser.
I know, the teaser. Jesse, do you want to say what we were talking about?
Which part?
Oh, no, the part that applies to CCGG.
We were thinking about doing tales from, or stories from the life of different careers. So I worked as a long-term care ombudsman and had some wacky, horrendous, and fascinating stories to tell. And Maria was talking about, tales from a gerontology professor, tales from an older adult. What else did you say?
Tales from a caregiver. Mm-hmm. I happen to know a woman who is she wrote a book about it, and she's in this whole thing. Her father married a woman who was, I think, 35 or 40 years younger than he was. And this was maybe her fifth marriage. So as soon as she got everything in her name and he died, she's already on to the next husband. Wow. So there's been a whole thing about caregiving and how to deal with all of that and possible elder abuse. So she would be amazing. Tales from a hospice worker, tales from an elder care attorney, Maribel, tales from a geriatrician, tales from an older learner, since we're talking so much about age-friendly university, and some research was presented today about actually speaking with older learners. We thought we could do a kind of tales or adventures from the perspectives of all these people. So maybe Jesse and I we'll talk about that some more and see if it's a possibility.
Sounds great. That's very exciting.
And we welcome ideas from anybody who's on these calls. If there's something that, again, we're a statewide organization, and so we have people from all over the place and from many different disciplines. So we welcome creative ideas.
One thought that I had earlier I wanted to throw out, and it came up with the presentation from San Francisco State. So Madeline and Amiko, we're going through the process at Sac State, and also just kind of finished our self-study. But one of the things that we want to do is our campus is very much into kind of anti-racism right now, which is fabulous. And so we have this Office of Diversity and Inclusion. But aging is missing from that. And so we want to try to get involved with that and really looking at the intersectionality of it with varying levels of receptivity. So I'm wondering, from other institutions, have you looked at kind of including aging on a larger university perspective on inclusive and diversity, and how has that been received, and maybe what strategies have you utilized to do that?
We have at Cal State Long Beach, we've made a concerted effort of our faculty has gotten themselves put on commissions and boards that are forming. So Dr. Marshall, for example, Mary, you are on the department. I felt like you were on one of the inclusive.
I'm on the university strategic enrollment committee. So looking at trying to get students from diverse backgrounds in all ways.
Great. And then Alex Wilkinson, who's one of the CCGG members at large, is also on a committee. And then we have another faculty member. We have a President's Commission of Equity, Inclusion, and Diversity. And so making sure that aging and ageism are on the table when we have those discussions. And believe me, Miriam, who's our person that's on that, she had to really overcome some barriers to getting that as a point of discussion, because faculty members were quite vocal about some of their perceptions, not across the board, but the ones that felt this way were very vocal, saying, well, universities are for young people. Wow. And as a professor, when I have a student over 40 show up in my classroom, I cringe, because it's going to slow down my classroom. I'm going to have to teach them about this. And it was a shock to us that there are people that not only feel that way, but are willing to be so vocal about it. But getting people on committees to make sure, that is always brought up is really important.
So that was actually one of my questions when I was listening to Amiko and Madeline talk about the work that they were doing. And as we continue to kind of think about age-friendly universities and the role that CCGG can play in promoting that and supporting that and advocating for that, I always come back to each campus. So I wanted to bring it to my campus, and it's still a possibility, but I'm always curious about the support of the administration, right? I mean, the culture in higher education right now is not always conducive to aging in general, right? Whether you have a program or you just have old people on campus, unless they're faculty. So I think that plays a really big role. You have to have that support.
Well, and I think that goes back to a question that was posed earlier about what is the benefit of being designated as an age-friendly university. When we show up at these meetings, we remind people, hey guys, we are designated as an age-friendly university. So we have to put our money where our mouth is. So we need to talk about this in this committee. So that's another good reason, because it's like we've got some backup where, again, it's the provost and president who had to sign off on us becoming designated. So right. Yeah, so when you can say this is something that's on their radar, people will listen.
That's right. It gives you the extra cachet, right?
Yep.
Something I think we should be working together is how to pitch this one, because I think it depends on who you're talking to. There's different reactions, but if you have a good package of information and easily sort of be presentable to even people who are skeptical about this, and then we could have a strong standing from the beginning too. So I feel like every time I talk to I get this different reactions, and some people are really enthusiastic, some people are really not really getting what I'm talking about. So I think that how we talk about it is really important. It's just an elevator pitch that we need to prepare.
I wanted to introduce myself.
Sorry, Pamela.
Oh, I just wanted to introduce myself. I'm a new face. I'm Pam Abbott, and I am Pauline's daughter. The apple doesn't fall far from the tree. But I'm on faculty at Sonoma State in what was the gerontology program that has now become a pod in the human development department, and I am the aging person there. But I'm also faculty at Chaffey College. And I'm not entirely sure how it happened, but I got approached by the folk at AARP, and our administration has jumped on the opportunity to be a part of the AARP age inclusion pilot that they are doing for large businesses.
Oh, great.
And we're going to have space for 25 to 100 of our faculty go through this really cool 2-hour facilitated program from AARP. I was surprised at how quickly the presidential board said, yes, 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 we will do this. But it's being done by AARP for larger companies. I believe their claim to fame is Avis Rental, or one of the large car rental companies, and Zappos are going through the same big corporate training to try to change some perceptions. And I'm doing their Disrupt Aging program in my classroom this summer to try and see whether that works. And but this is a whole new thing that they're doing, and I'm excited and suspicious and intrigued, and I'm starting the process with them now. So if anyone wants to know about what I'm doing here, I would love to share it as I go along, because we all have these little tiny pockets of perspective, and I think it's really interesting to see what industry is doing in the name of education or not. So it'll be intriguing.
Skeptically, yes.
Well, I live my life cautiously optimistic, Kelly. You know that.
That is right. So it's so nice to see your face here, Pam. I'm glad you're with us.
Thank you.
And definitely keep us posted. The part of what we do here is advocacy, and we want to support not only higher education, but individuals and anybody who is really trying to do anything related to aging. That would be within our mission for sure.
Okay, good.
Yeah.
We have a blog on our website too. That would be really fun. If any of you are doing any cool projects like this, please feel free to reach out, because we like to keep that information. We also, Mary and Kelly, we do a lot of social media stuff as well, but we have that blog for longer pieces, and we'd love to hear from any of you with whatever you're working on.
Sometimes we do social media. Actually, right at this moment, Mary, I'm trying to get you on as an admin for Facebook. So we're figuring it out so we can have some help here.
Mary is a social media guru.
I know, and I need her to be
She's amazing. She's kicked up our university's social media presence like 50-fold with her creativity.
And she probably knows what day it is on a regular basis. So
yes, that helps.
So are we wondering, so Donna, I don't know, do you and Maria, do you guys want to wrap this up by just inviting any more questions, or?
Yeah. If we know you have busy days, I know for those of us in academia, we're nearing toward the end of the semester. And so, always reach out to us. You've seen our faces now, so you know who we are. If you have a great idea that you want us to pursue, or if you're involved in any sort of advocacy work that you want us to consider, however it goes, please reach out. We're your organization, and please consider signing up as an official member.
Yeah, and for those of you that are graduating, get in now, because you can get in under the student rate.
Good. So, yeah.
Now's the time to join. So
even Jesse and Tasha, even though, you kind of this is kind of your official semester, so we'll count you as students if you want.
Get in.
One last perk.
Yeah, exactly. Well, thank you all so much. I think some of the board members are going to hang out. We're going to do a little debrief, but for everyone else, have a wonderful day. We hope to see you again soon. And congrats, Jesse. Great job.
Thank you. And thank you, everyone.
Thank you.
Have a wonderful day.
Thank you very much.
To those of you graduating.
Thanks.
Thank you. Bye-bye.
Bye.
Bye. Thank you.
Excellent.
Congratulations, Education Committee.
Yeah, great. Donna, do you want to turn the recording on?